Hi friends, welcome to PharmaGrid. So today we are going to learn about angina, which is also known as chest pain, its pathophysiology as well as the treatment options. Atherosclerotic disease of the coronary artery is also known as coronary artery disease, which is simply denoted as CAD, or ischemic heart disease, which is denoted as IHD, is the most common cause of mortality worldwide. Atherosclerotic lesions in coronary arteries can obstruct the blood flow, leading to an imbalance in the myocardial oxygen supply and demand that presents as stable angina or an acute coronary syndrome, which includes myocardial infarction or unstable angina. So in a nutshell, we can say that angina pectoris, which is one of the main symptoms of ischemic heart disease, is due to an imbalance between oxygen supply and oxygen demand of the myocardium. Spasms of vascular smooth muscle may also impede cardiac blood flow, thereby reducing perfusion and causing ischemia and angina pain. Typical angina pectoris is a characteristic sudden severe crushing chest pain, which is one of the important feature of angina. That is, the pain will be sudden, severe and crushing type of chest pain, and that may radiate to the neck, jaw, back and arms. All patients with ischemic heart disease and angina should receive guideline-directed medical therapy with emphasis on lifestyle modifications. Lifestyle modifications mainly include smoking cessation, physical activity as well as weight management, and also the management of modifiable risk factors such as hypertension, diabetes and dyslipidemia to reduce the cardiovascular morbidity and mortality. Coming to the types of angina, angina pectoris has three patterns. So the first one is stable, effort-induced, classic or typical angina. Second one is unstable angina. Third one is Prinzmetal, variant, vasospastic or rest angina. So in a nutshell, we can say that the main pathophysiology behind angina pectoris is increased myocardial oxygen demand and decreased myocardial perfusion. Now we will see in detail each types of angina. So the first one, stable angina, which is also known as effort-induced angina, classic or typical angina. So from the word itself, it is clear. Okay, stable angina. So it is characterized by episodes of chest pain commonly associated with exertion or due to some exercise. It is the most common form of angina, usually characterized by a short-lasting burning, heavy or squeezing feeling in the chest. Some ischemic episodes may present atypically in the sense with extreme fatigue, nausea or diaphoresis, while others may not be associated with any symptoms, which is known as silent angina. Atypical presentations are more common in women, diabetic patients and the elderly. Classic angina is caused by the reduction of coronary perfusion. Reduction of coronary perfusion means reduced blood flow to the coronary arteries or to the myocardium due to a fixed obstruction of a coronary artery produced by atherosclerosis. We know that these coronary arteries are mainly supplying blood to the myocardium or our heart. So if there is any obstruction happens or if there is any obstruction occurs within the coronary artery, the blood flow will be reduced. So this is one of the important reason for this stable angina or classic angina. Increased myocardial oxygen demand, such as that produced by physical activity, emotional stress or excitement, or any other cause of increased cardiac workload may induce ischemia. Okay, so these are certain cases. Physical activity, emotional stress or excitement. So in such conditions, the myocardial oxygen demand will be increased. Okay, so such cases will lead to increased cardiac workload and ultimately result in ischemia. Typical angina pectoris is promptly relieved by rest or nitroglycerin because stable, okay, from the name itself it's clear, stable angina, it is due to some exertion or any kind of exercise. So this type of angina can be relieved by taking rest or nitroglycerin. When the pattern of chest pain and the amount of effort needed to trigger the chest pain does not vary over time, the angina is named as stable angina. Next one is unstable angina. It is characterized by angina at rest. Unstable angina is chest pain that occurs with increased frequency, duration and intensity and can be precipitated by progressively less effort. Any episode of rest angina longer than 20 minutes, any new onset angina, any increasing angina known as crescendo angina or even sudden development of shortness of breath is suggestive of unstable angina. As the name indicates, the symptoms are not relieved by rest or nitroglycerin. Unstable angina is a form of acute coronary syndrome and requires hospital admission and more aggressive therapy to prevent progression to myocardial infarction and death. And the third type of angina is prinzmetal variant vasospastic or rest angina. Prinzmetal angina is an uncommon pattern of episodic angina that occurs at rest and is due to decreased blood flow to the heart muscle caused by spasm of the coronary arteries. Although individuals with this form of angina may have significant coronary atherosclerosis, the angina attacks are unrelated to physical activity, heart rate, or blood pressure. Prinzmetal angina generally responds promptly to coronary vasodilators such as nitroglycerin and calcium channel blockers. So far we have discussed about the three types of angina. Now we will see about acute coronary syndrome or ACS. Acute coronary syndrome is an emergency that commonly results from a rupture of an atherosclerotic plaque and partial or complete thrombosis of a coronary artery. If the thrombus occludes most of the blood vessel and if the occlusion is untreated, necrosis of the cardiac muscle may occur. So myocardial infarction is nothing but the necrosis of the cardiac muscles. It is typified by increases in the serum levels of biomarkers such as troponins and creatine kinase. The acute coronary syndrome may present as ST segment elevation myocardial infarction, non-ST segment elevation myocardial infarction, or as unstable angina. In unstable angina, increases in biomarkers of myocardial necrosis are not present. Now we will see about the treatment options. So the treatment is aimed at maintaining the balance between oxygen supply and demand. And here you can see the main categories of drugs that can be used for the treatment of angina. So the first one is nitrates, which is further subdivided into short-acting as well as long-acting. Short-acting nitrates include glyceryl trinitrate and isosorbate dinitrate given through the sublingual route. Then long-acting nitrates include isosorbate dinitrate, isosorbate mononitrate, erythritol tetranitrate, pentaerythritol tetranitrate. Then beta blockers such as propranolol, metoprolol, etinolol and others. Then calcium channel blockers mainly includes the dihydropyridines and non-dihydropyridines such as verapamil, diltiazem, amlodipine, nitroglycerin, etc. Then the one and only potassium channel opener which can be used as an anti-anginal drug is nicorandil. Then other anti-anginal drugs include trimetazidine, ranolazine, ivabradine, oxyfedrine and dipridamole. So other than the drugs, there are certain surgical options are available such as PTCA, that is percutaneous transluminal coronary angioplasty, then coronary artery bypass graft which is known as CABG. Treatment strategies. So as we have already seen that 5 types of drugs used either alone or in combination are commonly used to manage patients with stable angina, which includes the beta blockers, calcium channel blockers, organic nitrates, nicorandil and the sodium channel blocking drug which is ranolazine. So these are the main drugs that are mainly used for the treatment of angina. So these agents help to balance the cardiac oxygen supply and demand equation by affecting blood pressure, venous return, heart rate and contractility. All anti-anginal drugs have similar efficacy and are equally effective for the relief of anginal symptoms. For relief of acute angina and prevention of angina before events that cause acute angina, nitroglycerin. Nitroglycerin mainly through the sublingual tablets or translingual spray is usually the primary drug of choice. Then sublingual or chewable tablets of isosorbate dinitrate may also be used because these are short-acting organic nitrates. Okay, so they will provide quick relief. Hence, they can be used as first-line choice for the relief of acute angina and for the prevention of angina. For long-term prevention or management of recurrent angina, oral or topical nitrates, beta-adrenergic blocking agents, or calcium channel blocking agents can be used. Double or triple therapy is often needed to control chronic stable angina since patients with ischemic heart disease and angina can have several comorbidities and cardiac ischemic pain might result from various underlying pathophysiologies. Some anti-anginal agents have additional properties that could be useful depending on comorbidities and the mechanisms of the angina. The dosage of all anti-anginal drugs should be individualized to achieve optimal benefit and minimal adverse effects. This is usually accomplished by starting with relatively small doses and increasing them at appropriate intervals as necessary. Adverse drug effects such as hypotension and syncope are more severe in elderly than in younger adults. In this slide, we can see the treatment algorithm for improving symptoms in patients with stable angina. So if a patient diagnosed with stable ischemic heart disease, so first we can go for the lifestyle modifications if there is no symptoms are present or if it is in the early stage. So in such cases, guideline directed medical therapy, including emphasis on lifestyle modifications for cardiovascular risk reduction. And if anginal symptoms are present, start with sublingual nitroglycerin for immediate or acute relief. Then add beta blocker. Okay, and if even after adding beta blocker, if there is an inadequate relief, okay, inadequate relief after titration, the physician can add either calcium channel blocker or long acting nitrate. Okay, again, if there is inadequate relief, the last option is ranolazine. Okay, so this is how the treatment chart or treatment algorithm for stable angina. So here you can see the treatment of angina in patients with concomitant diseases. So as you already know, usually most of the patients with angina will have certain other comorbid or concomitant diseases. So it is very important to choose the drug according to the patient's condition. So here you can see the concomitant diseases and here the drugs commonly used in treating angina. So those given in black are the most commonly used drugs, whereas those given in white is less effective drugs. So if there is no other comorbidities, we can use these all drugs such as long-acting nitrates, beta blockers and calcium channel blockers as the treatment options for angina. And if the patient has angina along with he had a recent myocardial infarction. So in such patients we cannot use calcium channel blockers. So in such patients long-acting nitrates and beta blockers are the most commonly used drugs. Then if the patient has comorbidity such as asthma or COPD, in such patients, beta blockers are contraindicated, especially non-selective beta blockers. So long-acting nitrates and calcium channel blockers will be the treatment options in patients with comorbidities such as asthma or COPD. Then if a patient has angina along with hypertension, beta blockers and calcium channel blockers will be the most commonly used drugs. Long-acting nitrates will be less effective. Then if the patient has angina along with diabetes, beta blockers are not used. Long-acting nitrates and calcium channel blockers will be the most commonly used drugs. Then if the patient has comorbidity as chronic renal disease, in such patients beta blockers will be less effective. Long-acting nitrates and calcium channel blockers will be the treatment options for a patient having angina and chronic renal disease together. Now we will discuss each category of anti-anginal drugs in detail. So the first one, organic nitrates. These compounds cause a reduction in myocardial oxygen demand followed by relief of symptoms. They are effective in stable, unstable or variant angina. Organic nitrates are prodrugs and they release nitric oxide. Nitrates are mainly venodilators, also cause arteriolar dilatation and as a result reduce both preload and afterload. Now we will see the mechanism of action. So organic nitrates relax vascular smooth muscle by their intracellular conversion to nitrite ions. Okay, so this is very important. So the organic nitrates mainly act by converting into or their conversion to nitrite ions and then to nitric oxide, which in turn activates guanylate cyclase and increases the synthesis of cyclic GMP, that is cyclic guanosin monophosphate. So this elevated cyclic GMP ultimately leads to dephosphorylation of myosin light chain. So dephosphorylation of myosin light chain means there will be reduced concentration of calcium in the cytosol. If there is a reduction in the calcium, what will happen? It will result in the vascular smooth muscle relaxation. Okay, so if there is an increase in cyclic GMP, it will lead to dephosphorylation of the myosin light chain that will lead to reduced calcium concentration in the cytosol and ultimately resulting in vascular smooth muscle relaxation. Nitrates such as nitroglycerin cause dilatation of the large veins which reduces the preload. Preload means venous return to the heart and therefore reduces the work of the heart. Nitrates also dilate the coronary vasculature, providing an increased blood supply to the heart muscle. So here you can see the flow chart, which will be very easy to understand the mechanism of action of nitrates. So here you can see the administered nitrates that will convert to nitrites, which will further get converted to nitric oxide. So this nitric oxide will lead to increased cyclic GMP, that is cyclic guanosine monophosphate. So increased cyclic GMP ultimately resulting in dephosphorylation of myosin light chain, thereby reduced calcium concentration in the cytosol, and at last resulting in the vascular smooth muscle relaxation. So vascular smooth muscle relaxation in the sense mainly they will cause venodilation, then arterial dilatation and dilatation of the coronary blood vessels also. So this diagram will be helpful to understand the pharmacological actions of nitrates. So these nitrates have no direct action on the heart. They are mainly acting on the vascular smooth muscles, and their main three pharmacological actions include venodilatation, which is a predominant effect, then arterial dilatation as well as dilatation of the coronary blood vessels. So first we will see about venodilatation. It is nothing but the dilatation of the veins, which will lead to peripheral pooling of the blood. As a result, there will be decreased venous return to the heart, which will lead to decreased preload and decreased left and right end diastolic volume and pressure. So ultimately, it will lead to decreased cardiac work and thereby reducing the oxygen requirement of myocardium. So what will be the result? There will be relief of anginal pain. So this is about the venodilatory action of nitrates. Next is the arterial dilatation, or we can say that it will be dilation of the arteries. So this will lead to decrease in the peripheral vascular resistance, that will lead to decrease in the afterload. Okay, so if the afterload is decreased, what will happen? The oxygen demand also will be decreased. So that also will result in the relief of anginal pain. And the next one is the dilatation of the large coronary vessels and collateral vessels. So this will lead to increased blood flow to the myocardium, especially to the ischemic area due to redistribution of coronary blood flow. So this will result in increased oxygen delivery to the ischemic area, which will be helpful to relieve the anginal pain. So this is how this organic nitrates helps to relieve the anginal pain. Coming to the pharmacokinetics of organic nitrates, these drugs are readily absorbed through the buccal mucous membrane, the skin and the gastrointestinal tract. All nitrates except isosorbate mononitrate undergo extensive first-pass metabolism. Hence, oral bioavailability of nitrates is very low. Sublingual route produces rapid onset, that is 2 to 5 minutes, but short duration of action. Absorption through skin is slow, hence this route is used for a prolonged effect. The metabolites are excreted mainly in urine as glucuronide derivatives. Nitrates differ in their onset of action and rate of elimination. The onset of action varies from 1 minute for nitroglycerin to 30 minutes for isosorbate mononitrate. Sublingual nitroglycerin, available in tablet or spray formulation, is a drug of choice for prompt relief of an angina attack precipitated by exercise or emotional stress. All patients should have nitroglycerin on hand to treat acute angina attacks. Significant first-pass metabolism of nitroglycerin occurs in the liver. Therefore, it is commonly administered via the sublingual or transdermal route, which is mainly through the application of patch or ointment, thereby avoiding the hepatic first-pass effect. Isosorbate mononitrate owes its improved bioavailability and long duration of action to its stability against hepatic breakdown. Oral isosorbate dinitrate undergoes denitration to 2 mononitrates, both of which possess anti-anginal activity. So in this slide, you can see the time to peak effect and duration of action for some common organic nitrate preparations. So onset of action means if a drug is administered, so how much time it will take to produce the action, or at what time the particular drug produces its action, which is known as the onset of action of a particular drug. And duration means how long the produced effect will be sustained, which is known as the duration of action. So let's first take the case of nitroglycerin, sublingual tablet or spray. It has got the quickest onset of action, that is 1 to 3 minutes, and duration of action about 25 minutes. Then coming to the oral or sustained release forms of nitroglycerin, onset of action 35 minutes, duration of action 4 to 8 hours. Then transdermal drug delivery system produces the onset of action within 30 minutes and duration of action is about 10 to 12 hours. Now coming to isosorbate dinitrate, the sublingual dosage form has got again the quick onset of action, that is about 5 minutes, then duration of action about 1 hour. Then oral sustained release dosage forms, quick onset of action is about 30 minutes and duration of action about 8 hours. Then isosorbate mononitrate, the oral or extended release dosage forms, onset of action is about 30 minutes and duration of action is greater than or equal to 12 to 24 hours. Then regarding the adverse effects. So the adverse effects are mainly due to extensive vasodilation. So headache is the most common adverse effect of nitrates. High doses of nitrates can also cause postural hypotension, facial flushing and tachycardia. Now let's discuss one of the important drug-drug interaction, that is between this organic nitrates and phosphodiesterase type 5 inhibitors. For example, sildenafil. Okay, so the sildenafil when taken together with the nitrates, what will happen? These phosphodiesterase type 5 inhibitors such as sildenafil, they will potentiate the action of nitrates. Okay, so ultimately it will result in hypotension. So to preclude the dangerous hypotension that may occur, this combination is contraindicated. That is organic nitrates with a sildenafil or phosphodiesterase type 5 inhibitors. Then another important point is about the tolerance. Tolerance to the actions of nitrates develops rapidly as the blood vessels become desensitized to vasodilatation. Tolerance to nitrates occur on prolonged use. They also exhibit cross tolerance. So about the management of tolerance, okay, we can use nitrate-free interval. So this is one of the most widely used method. Also we can use N-acetylcysteine and antioxidants such as vitamin C. Tolerance can be overcome by providing a daily nitrate-free interval to restore sensitivity to the drug. The nitrate-free interval of 10 to 12 hours is usually taken at night when myocardial oxygen demand is decreased. However, variant angina worsens early in the morning, perhaps due to circadian catecholamine surges. Therefore, the nitrate-free interval in patients with variant angina should occur in the late afternoons. Okay, this is one exception in case of variant angina. So for remaining all patients, the nitrate-free interval of 10 to 12 hours is usually taken at night because at the night time the myocardial oxygen demand is decreased. Then the nitroglycerin patches are worn for 12 hours and then removed for 12 hours to provide the nitrate-free interval. Now let's discuss about the next category of anti-anginal drugs, which is the beta-adrenergic blockers. So these drugs block the beta-1 receptors of the heart and thereby decreases the heart rate, force of myocardial contraction, cardiac work and ultimately reducing the myocardial oxygen consumption. Okay, so this is the mechanism of action of beta-adrenergic blockers. These drugs decrease the oxygen demands of the myocardium by blocking beta-1 receptors, resulting in decreased heart rate, contractility, cardiac output and blood pressure. These agents reduce myocardial oxygen demand during exertion and at rest. As such, they can reduce both the frequency and the severity of angina attacks. Beta blockers can be used to increase exercise duration and tolerance in patients with effort-induced angina. Beta blockers are recommended as initial anti-anginal therapy in all patients unless contraindicated. The exception to this rule is vasospastic angina, in which beta blockers are ineffective and may actually worsen the symptoms. Beta blockers reduce the risk of death and MI in patients who have had a prior MI and also improve mortality in patients with heart failure with reduced ejection fraction. And there is one disadvantage associated with the use of beta blockers. As we all know, the beta blockers act on the beta 1 receptors of the heart and thereby decreases the heart rate and myocardial contractility, which will result in the reduced cardiac output. Okay, so this reduced cardiac output or decreased cardiac output will result in increased left ventricular end diastolic volume and pressure. So this may increase the myocardial oxygen requirement. So this disadvantage of beta blockers can be counteracted by combining nitrates with a beta blocker. Agents with intrinsic sympathomimetic activity such as pintolol should be avoided in patients with angina and those with a history of myocardial infarction. Beta blockers such as metoprolol and atenolol are the preferred drugs. All beta blockers are non-selective at high doses and can inhibit beta 2 receptors as well. Beta blockers should be avoided in patients with severe bradycardia. However, they can be used in patients with diabetes, peripheral vascular disease, and chronic obstructive pulmonary disease as long as they are monitored closely. Non-selective beta blockers should be avoided in patients with asthma. It is important not to discontinue beta blocker therapy abruptly. The dose should be gradually tapered off over 2 to 3 weeks to avoid rebound angina, myocardial infarction, and hypertension. Moving on to the next category, which is the calcium channel blockers. So we know that calcium is essential for muscular contraction. Calcium influx is increased in ischemia because of the membrane depolarization that hypoxia produces. In turn, This promotes the activity of several ATP consuming enzymes, thereby depleting energy stores and worsening the ischemia. So here comes the action of calcium channel blockers. So these voltage sensitive calcium channels are of 5 subtypes. They are L, N, T, P and R subtypes. So L type is predominantly present in cardiac and smooth muscle cells. So these calcium channel blockers block voltage sensitive L type calcium channels and thereby prevent the entry of calcium into the cell. As a result, there will be no excitation contraction coupling in the heart and the vascular smooth muscles. So in a nutshell, we can say that the calcium channel blockers protect the tissue by inhibiting the entrance of calcium into cardiac and smooth muscle cells of the coronary and systemic arterial beds. All calcium channel blockers are therefore arteriolar vasodilators that cause a decrease in the smooth muscle tone and vascular resistance. These agents primarily affect the resistance of peripheral and coronary arteriolar smooth muscle. In the treatment of effort-induced angina, calcium channel blockers reduce myocardial oxygen consumption by decreasing vascular resistance, thereby decreasing the afterload. Their efficacy in vasospastic angina is due to relaxation of the coronary arteries. Verapamil, which is a phenyl alkylamine derivative, it mainly affects the myocardium, whereas amlodipine, which is a dihydropyridine derivative, it exerts a greater effect on smooth muscle in the peripheral vasculature. Diltiazem is intermediate in its actions. All calcium channel blockers lower blood pressure. Then about the dihydropyridine calcium channel blockers. Amlodipine, which is an oral dihydropyridine, has minimal effect on cardiac conduction and functions. It mainly functions as an arteriolar vasodilator. The vasodilatory effect of amlodipine is useful in the treatment of variant angina caused by spontaneous coronary spasm. Then the next drug is nifedipine. It's usually administered as an extended release oral formulation. Short-acting dihydropyridines should be avoided in coronary artery disease because of evidence of increased mortality after an MI and an increase in acute MI in hypertensive patients. Moving on to the non-dihydropyridine calcium channel blockers. So under this category comes the verapamil, which is a phenylalkylamine derivative, and diltiazem, which is benzodiazepine derivative. So this verapamil, it is a phenylalkylamine and has got predominant action on the heart. It slows atrioventricular conduction directly and decreases the heart rate, contractility, blood pressure and oxygen demand. Verapamil has greater negative inotropic effects than amlodipine, but it is a weaker vasodilator. Verapamil is contraindicated in patients with pre-existing depressed cardiac function or AV conduction abnormalities. Diltiazem also slows AV conduction, decreases the rate of firing of the sinus node pacemaker, and is also a coronary artery vasodilator. Diltiazem can relieve coronary artery spasm and is particularly useful in patients with variant angina. Non-dihydropyridine calcium channel blockers such as verapamil and diltiazem can worsen heart failure due to their negative inotropic effect, and their use should be avoided in this population. The next category of anti-anginal drug is potassium channel openers. So the example is nicorandil. It is a vasodilatory drug that functions through potassium channels and intracellular cyclic GMP concentrations commonly used to treat angina. So how this nicorandil will work? This drug open the ATP dependent potassium channels. So what will happen? We know that the intracellular concentration of potassium is much higher compared to the extracellular. So if the potassium channel opens, what will happen? There will be outflow of potassium ions, or we can say that there will be potassium efflux. So the potassium will move out of the cell. That will lead to hyperpolarization of the membrane. Okay, hyperpolarization of the membrane. So this nicorandil is a potassium channel opener with a nitrovasodilator actions, means it is an NO donor, making it both an arterial and a venous dilator. It is indicated for the prevention and treatment of chronic stable angina pectoris and reduction in the risk of acute coronary syndromes. It serves as an effective anti-ischemic drug in patients with contraindications to beta blockers such as bradycardia and aggravated pulmonary disease. Moreover, the adverse effects are negligible, including frequent headache and less frequent dizziness, gastrointestinal discomfort, flushing and malaise. So again here the mechanism of action of nicorandil is explained here. Nicorandil is a dual action potassium channel opener that relaxes vascular smooth muscle through membrane hyperpolarization via increased transmembrane potassium conductance and increased intracellular concentration of cyclic GMP. So the activation of potassium channels leads to hyperpolarization of the smooth muscle cells followed by arterial dilatation and afterload reduction. Nicorandil is shown to increase pooling in the capacitance vessels with a decrease in preload through relaxing the venous vascular system. So, hence this Nicorandil decreases the preload as well as the afterload. Hence, it acts as venodilator as well as arterial dilator. Overall, improved blood flow and reduced infarct size are achieved through reduction of end diastolic pressure and decreased extravascular component of vascular resistance. And the vasodilator action partially antagonized by potassium channel blockers such as glibenclamide, which is an oral hypoglycemic drug. Then, as I have already mentioned, Nicorandil acts as an NO donor. So, it has the capability to relax the blood vessels by increasing the cyclic GMP, mainly administered orally, efficacy similar to nitrates, beta blockers or calcium channel blockers, and it has got cardioprotective property by mitochondrial K plus ATP channel opening. And the one advantage of Nicorandil is that it has got longer duration of action and the dose is mainly 5 to 20 milligram twice daily. Next category is sodium channel blocker. Example is ranolazine. This drug inhibits the late phase of the sodium current, improving the oxygen supply and demand equation. Inhibition of late sodium current reduces the intracellular sodium and calcium overload, thereby improving diastolic function. Ranolazine has anti-anginal as well as anti-arrhythmic properties. It is most often used in patients who have failed other anti-anginal therapies. The anti-anginal effects of ranolazine are considerably less in women than in men. This drug is extensively metabolized in the liver, mainly by the CYP3A4 and also by CYP2D6. It is also a substrate of P-glycoprotein. As such, ranolazine is subject to numerous drug-drug interactions. In addition, ranolazine can prolong the QT interval and should be avoided with other drugs that cause QT prolongation. So this slide provides a summary of characteristics of anti-anginal drugs. So which all are the main anti-anginal drugs? That is the beta blockers, then calcium channel blockers. Under the calcium channel blockers, dihydropyridine calcium channel blockers as well as non-dihydropyridine calcium channel blockers, then organic nitrates, potassium channel opener which is the Nicorandil, and then ranolazine. Okay, and what all are their common adverse effects? Suppose in case of nitrates, their important adverse effect is headache. And regarding the calcium channel blockers, one important side effect is peripheral edema or angle edema. And what all are their important drug-drug interactions? As we have already discussed, contraindication. Okay, contraindicated. For example, the use of organic nitrates with the phosphodiesterase 5 inhibitors. They are contraindicated because of severe hypotension. And what all are the other specific notes related to each category of anti-anginal drugs? For example, in case of nitrates, ensure nitrate-free interval to prevent tolerance. Okay, so likewise. So you can refer this slide for further clarification or further details regarding the anti-anginal drugs. Hope you all have liked this video. Thank you everyone for watching and supporting me. Please like, share and subscribe. Have a good day.